A very good morning to all.
All right.
So the title of my presentation is Outcomes of Amniotic Membrane Transplantation in Acute Stevens-Johnson Syndrome Toxic Epidermal Necrolysis Disease Spectrum. We all know that Stevens-Johnson syndrome is a systemic disease, and it involves not only the skin, it involves skin and at least two mucosal surfaces, and ocular surface is not an exception. So this is a schematic diagram where we can see what exactly happens to the ocular surface, wherein there is total desquamation of the epithelial cells. Depends on the severity of the disease. There can be total desquamation of the ocular surface. And so the purpose of this study was to evaluate the outcomes of amniotic membrane transplantation in the acute phase of Stevens-Johnson syndrome and toxic epidermal necrolysis. So it was basically a retrospective chart review, and the duration of study was from January 2021 to December 2023. And patients with Stevens-Johnson syndrome and 10 disease spectrum with ocular involvement were included in the study. A total of 13 patients were included in the study, and all the patients were evaluated thoroughly at bedside, and they were started on topical steroids, prophylactic antibiotics, and intense lubrication. All patients received single dose of IV methylprednisolone, and subsequently they were kept on systemic cyclosporin. Out of these 13 patients, only 10 cases were qualifying for the amniotic membrane grafting, of which 3 patients denied amniotic membrane grafting. However, 7 consented for it. The one who denied were managed conservatively, and rest underwent amniotic membrane with symblepharon ring. The symblepharon ring was made out of an infant feeding tube, and all these cases were further followed up for a period of 1 year, and the outcome parameters observed were direct assessment of tear secretion, tear breakup time, Schirmer's, lid margin keratinization, and keratopathy. This was the kit that was used for all cases. Here is a small video on how we went ahead with doing amniotic membrane grafting in patients with Stevens-Johnson syndrome. First, this ocular surface was thoroughly washed. The necrosed conjunctival membranes were peeled off. The symblefra were released. The fornices were swept. Speculum was inserted to facilitate amniotic membrane graft spread. The amniotic membrane in place was first then anchored using this symblepharon ring, which was made out of an infant feeding tube. And subsequently, the rest of the redundant amniotic membrane was reflected onto the lid margin. So in our case, we noted that 3 cases which refused to undergo amniotic membrane grafting. Almost all patients by the end of 1 year had developed lid margin keratinization, and subsequently they required oral mucous membrane grafting. However, the 7 cases who underwent amniotic membrane grafting, 6 cases had no lid margin keratinization. They also had at least 3 patent lacrimal ductules, which we assessed on doing direct assessment of tear secretion. One case which underwent amniotic membrane grafting, however, still developed lid margin keratinization and had just 1 patent lacrimal ductule. There was peripheral superficial vascularization in the cornea, and there was severe dry eye in 1 case which underwent amniotic membrane grafting. One important point that we noticed was that almost all cases who even underwent amniotic membrane grafting had DATs showed that at least 3 ductules were patent, 3 lacrimal ductules were patent. However, there was some lag of around 2 to 3 seconds in tear secretion. So at the end of 1 year, the patients who underwent amniotic membrane grafting had a clear cornea. There was conjunctival scarring with meibomian gland atrophy. However, there was no significant lid margin keratinization. On direct assessment of tear secretion, we noted that these serial photographs shows how active tear secretion was happening even at the end of 1 year. So the purpose of doing this, though even the literature is flooded with so many publications where they said that lid margin to lid margin amniotic membrane grafting really helps in patients in acute Stevens-Johnson syndrome, specifically in patients who had acute ocular manifestations. In this study, we used a symblepharon ring, which was made out of an infant feeding tube. So how it worked was that the ring was very pliable. We measured the palpebral aperture of the patient, horizontal palpebral aperture, and we used the formula 2 pi r, and we calculated, and based on that, we designed we created the symblepharon ring. So this ensured that when it's placed into the conjunctival cul-de-sac, it takes the form of or it molds itself along the furnaces and allows the close apposition of amniotic membrane even to the supratemporal furnaces where the amniotic membrane, where the lacrimal ductules open. So with this, I would like to conclude that early intervention is in the form of amniotic membrane grafting, prevents long-term sequelae, and contributes in decreasing the morbidity. Thank you.
Thank you, and very nice study.
Thank you so much, sir.
Thank you very much.